I'm Myra Robson and I'm a clinical lead physiotherapist from London.
I'm Josephine. I'm a part-time postgraduate student, mature, but I also sit on the patient advisory committee at the International Urogynecological Association. It's quite a mouthful.
Okay, and my name is Ville Pernu, and I work as a peer counsel in Tampere University Hospital for spinal cord injury victims.
So we've been having a really interesting chat this afternoon, and I've been learning a lot from both of you, having worked in this field of pelvic health for many, many years. But the more experienced I get, the more I realise that there's so much I don't know. And you've both said some really interesting things today that has made me think about things in a different way. So Josie, can I ask you to explain a little bit about what happened in childhood and the impact of your symptoms on your life now?
Yeah, so I have, as I said, I have overactive bladder, which varies in severity. I think the last time I had urodynamic testing, I was told that it was severe, but I've been wet for most of my life. So I definitely think from when I was about 5, I think I went through that toddler milestone of being dry. So as a child, so it's pretty grim living with it in adulthood, and one sort of learns to manage or not manage it. But as a child, I didn't really have any idea. I was just sort of incontinent. And the way that it was managed or treated by clinicians was that it was attention seeking or it was psychological. And I've sort of just told you, and I've spoken to other people about this, that there was the classic gold star sticker. This was in the 1970s as to when she's being dry, acknowledge that she's dry and she's doing it for attention, but, it's the whole reward thing. That changed to more sort of punishment, and I'm really cautious about. I don't really like talking about this because it infers blame on my parents, and I don't blame them at all because I think that it must be. It was very tiring and exhausting for them trying to sort of help me. I was wet at night as well. So I remember, as I've discussed, that being about 13 and seeing a paediatric urologist who said, this is ridiculous. She's still doing it for attention. She should have grown out of it. Get her to hand wash during the school holidays, her clothes and her sheets and so on and so forth. And that thing with eczema on the skin, because I was looking out of our garden in Cambridge, out at our garden and having to hand wash. And that's what my parents were told. That was what my mother was told by. And in the 80s, you demurred, you deferred to the consultant, the all-powerful consultant. It was far less multidisciplinary care in those days. Had bladder ablation, and it went right through. And I was only formally diagnosed, and I've said this many times, in my mid-30s, and it was a weight off my shoulder because it was confirmation to me that it wasn't in my mind, and it wasn't, it wasn't my fault. Or the problem is, by that stage, it had sort of become part of in my mind because it had had such a profound impact on my mental health in childhood, in adolescence, and in fact in adulthood. And the mind is a wonderful, all-encompassing thing, but it's not just biological. It's not just psychiatry. We are a product of our childhood and how I managed my secrecy and so on and so forth. So that's my that's rather my detailed, and I've discussed it before, but hopefully that puts you in the picture.
No, it's really interesting. And Ville, for you, 10 years ago, you had a spinal cord injury. So you went within minutes of being sporty, active, fully functioning to being quite the opposite. What's it like to acquire such a sudden bladder and bowel problem amongst all the other problems that you had to deal with?
Well, of course, the bladder and bowel problems are something that comes along with spinal cord injury, almost always. And that is not something that is on top of your mind in the beginning, because you have a ton of problems. This is one of them, and you don't really pay attention to those things when you are lying in the hospital bed, thinking about whether I can ever walk again, use my hands again, or something like that. It comes into focus later on when the normal life is supposed to begin. A few months of recuperation and rehabilitation, and your motor skills get stabilized into some sort of functionality, and after that you have to start living your life again, and that's when these kind of toilet things are coming to the foreground if there are problems. So it's of course very important that you start managing those problems before they even surface. And of course we have this advantage to you. We don't have this plain thing. We have the reason for our incontinence already given to us. We know what's the cause, and from the beginning it's regarded as normal. It's normal for us. It's nothing nothing different. It doesn't make us different, because when we are in rehabilitation there are plenty of us with spinal cord injury, and we talk about it. Okay, what kind of problems do you have? What kind of problems do you have? I have this kind of problems, and we all have problems. They just vary in degrees. So that's a very good starting point for this kind of life. What was your question?
Well, how did you adjust to the bladder and bowel problems?
Yes, well, that was the beginning of the adjustment. Of course, the adjustment, you have to start learning how often you have to catheterize, what's the best way to catheterize, and how often you have to go to the toilet for a bowel movement. And I have no feeling in my body, so I have to start learning when the nurse that handles my bowel movement does her or his job. I have to monitor the process, and I also have to give input when I think we've done good enough job, so that the next 24 hours I can go on with my life safely without any fear of accidental fecal explosions or anything like that. In the beginning, there were a couple of years which the situation was pretty uncertain. Every now and then there were accidents, but you learn. When the nurse does his or her thing during the toilet time, I've developed this skill of knowing, okay, this is the rhythm that my bowel works, and this is the amount that is expected every 24 hours. So, okay, now I know that we can pretty safely say that this is all that's gonna come out of me today. So it's a learning process. It takes a few years.
Years. Wow.
Few years, yeah, it's not a quick thing.
Yeah.
So you have to be ready for unexpected, unpleasantries. But I think it's been almost 6 or 7 years since my last unexplained accident.
Okay.
Oh,
It can always accidents can always be attributed to if you are sick, you have stomach flu or something like that, or too much alcohol.
Yeah.
That's one reason why I haven't touched alcohol in many, many years, because it makes me uncertain of myself.
Yeah.
That's a well, I wasn't heavy drinker before, but I would drink even less now.
Can I ask you a question?
Yeah,
Did
please.
you have continence support right from just sort of after your injury? So the rehabilitation, when the rehabilitation started, did that involve continence support, or did that come afterwards?
It involves counseling about the subject. We had courses, for example, not that much in here in Tampere at that point, but I spent 3 months in Helsinki, where they had have this specialized rehabilitation clinic, and they had plenty of knowledge over there, and they had lectures, and they had specialists. I had and the nurses were very, very experienced about this thing, so there was a ton of knowledge. I was so much wiser after that process. I knew a lot after that, so it was a very, very efficient process I went through. And here in Tampere, we've also adopted similar methods. Hopefully we are as good as they were over then.
So it's adopting best practice from elsewhere.
Yeah.
And I don't know about you, but I think that one of the most important thing is professional curiosity.
Yes.
Yes. And being ready to learn something different.
Yeah.
Yeah, that's very important. Bringing new technologies, ideas, methods,
Yeah.
trying them out. As we have those presenters outside this room, and there are a couple of things that I recommended them that, okay, please contact our hospital, because they should be, it's in their mandate to be interested in new things.
Yeah, absolutely.
You have to try them out, or at least take a look at them.
Yeah, and I think the whole thing with working with industry or collaborating with say device manufacturers has often been, it's often been missing. So that whole sort of co-production and so on and so forth. So rather than taking it beyond making suggestions, is actually working right from the start with people that do suffer from incontinence, or it could be anything. Rather than, because they might have great ideas, but those ideas might not resonate with the people that are experiencing the, and just we were talking, weren't we, about, how you use your wheelchair, and the English expression about, or spend a day in my shoes. And, we were just talking about, how you get around and the basic, the day-to-day challenges and your special key fob. And things like that had never occurred to me since, prior to us talking. So
Another idea would be spend a day in a diaper.
Yes, yes.
yeah.
Go about your business and do urinate in a diaper.
Yeah.
That's what's really interesting, I think, about this these 2 days, is that, pads are often seen as the default. They're not particularly pleasant. I'd rather, look at other things. So the other English expression is shutting the stable door after the horse has bolted. Well, try and look at other treatment modalities. Some people need to use pads. There is an inevitability. But there seems to be a drive with normalising incontinence, and I think that we need to do an awful lot of work around stigma. But if incontinence, there's a problem for me with normalisation, and we've spoken about pads, if we just grab a pad, almost like a sort of security blanket, rather than actually how we can look at treating, might not be a cure, but how we can sort of take a step back, and maybe looking at more preventative sort of ways of looking at things, rather than just throwing a pad at the issue.
We've been talking about sustainability the last couple of days, and sustainability means different things to different people. But one of the key ones is cost. Now, you two will have received a lot of public health care, but I'm interested in what hidden costs that you've had to...
I haven't received, I haven't, not, well, the National Health.
Yeah, but what costs have you incurred that we might not think of? What things do you have to do differently than I might need to do that cost you money?
Well, actually, we've spoken about this before, is laundry and so on and so forth. And I've discovered in the UK that if people are on a low income and they have incontinence, they qualify for a reduction on water bills. But obviously, increased energy costs with needing to, not just personal hygiene, but needing to launder more often. And I also think with me, I had very, very profound depression. I don't know how much of that was independent of my continence, how much was associative. So that has had an impact on my ability to work. And, you know, my having the confidence to leave home, to actually sort of stand up and do things. And, you know, compared to you, where, I just look and I'm full of awe, people might think, well, her issues are quite minor. But they've not had a minor impact on me. So there has been, in terms of my sort of employment and so on and so forth, there's been an impact on my earning potential.
Yeah, interesting.
Yeah, that hidden cost in Finland here, for an individual being a disabled person isn't that expensive. Of course, some medications you have to pay for yourself. They may cost somewhat a lot, but it's not that much. But of course, lost earnings is something that is very significant.
Yeah.
And as we talked about earlier, incontinence is not something to be scoffed at as a problem, because, for example, for spinal cord injury patients, the bowel and bladder problems are the most significant limiting factor in the quality of life. It's not the motor skills or the lack of them. It's the bowel and bladder control things. So in that sense, we are in the same boat.
Yeah, it's, I wonder if sort of people look at the wheelchair and they think, wow, you know, that's really sort of profound and so on and so forth, major injury. But the things such as continence, people don't think about as much, or they're sidelined a little bit. And it sounds like your care has been really good in that regard. You know, it wasn't sort of sidelined, or it wasn't brushed under the carpet.
No.
Yeah, because obviously sounds the place to be actually in terms of best practice.
Yeah, well, it's a problem, as you said, that at some point, if you go to a regular doctor that has no expertise in for example, neurological bladder, hasn't ever heard of it or at least read about it, so doesn't know what it is, it might just run out of ideas and say that, okay, it's in your psychic, it's a psychological problem, go to a psychiatrist, get out of my office.
Yeah.
Something like that. So.
And one thing that's just occurred to me is that you've said about Tampere, it sounds like a centre of excellence. And I live in London and I'm a patient at a tertiary care unit, which, you know, and in London, there's some great places where Myra is. But we talk about global health inequalities when it comes to continence. But I think that there are, certainly in the UK, we have inequalities within the UK. And I don't just mean sort of demographic in terms of race, gender, age, sex, so on and so forth, but accessibility, physical accessibility, that, you know, if you live in a rural area or somewhere that's, you know, where there isn't tertiary or even very good secondary care, what do?
It's the same here.
Yeah.
We have the same problem.
And there again, I think that's when curiosity comes in. And I can remember my current GP, who's very, very good, said several years ago, he referred me back to the tertiary centre because it hadn't got any better. I know that I can't be cured. And he said to me, and he's quite Eeyore-ish, you know, the Winnie the Pooh and a bit... but he actually said to me, "Oh, that's so distressing. I'm going to refer you back." And that for me was quite comforting because it was an affirmation. Whereas I think I mentioned yesterday that I sat in a lecture a couple of years ago, and it was given as part of my master's, if I ever finish it, by my health policy lecturer, who had sent practicum exercise in advance of the lecture, and it was basically, if you pardon the pun, poo-pooing overactive bladder and indeed menopause. The irony is that she was party to my health records, which included overactive bladder, and it was really quite sort of distressing because you're sitting in a lecture theatre with someone who knows your condition. And it's a little bit niche. I know it's quite common, but, you know, it's often associated with ageing and so on and so forth. And it just seemed to, you know, I mentioned the term epistemic injustice a lot, but it was a bit of a kick in the teeth.
Mm-hmm. I was really interested yesterday when Eamon commented that people go to their GP or their healthcare provider and they'll discuss their incontinence once. And if they're dismissed, they will probably never go back and discuss it again. And that really struck me. I'd never heard that before. And if we're talking about sustainability of quality of life, of career, of relationships, and all of these are connected with incontinence, can you think of any episodes of care with a healthcare provider, other than when you were a child, that have been really poor and that could, if your condition was less severe, could have just been enough to send you scuttling?
Well, you see, I didn't engage in terms of my bladder for years and years and years and years and years. So I had that child, you know, I had that young adolescence intervention, and then I had a bladder ablation, I think, when I was about 17. And then from then on, I was prescribed medication, which most of the time I didn't take because the side effects didn't agree with me. So if I'm thinking 17... and then I was referred back. So that's nearly 20 years when on my records it said that I was incontinent. But it was, I never spoke about it because it was just something that, well, you know, it's become a bit of a fact of life. So, you know, it's interesting that so it's nearly 20 years before the subject arose again. Do they use, I think they use, we use the expression door handle moment.
Latchkey incontinence.
Yeah, but so it's one of those things that someone might discuss on their way. So they'll go for a consultation with their GP about something.
Just as you're leaving the room.
Yeah, about something completely unrelated, and then as they're going out the door, they'll mention it. And I think it's perhaps incontinence in whatever form is perhaps one of those door handle moments.
And what made you go back again and actually do something about your condition?
I think I'd had some major public voiding, and I'd walked. I just was finding it really, really difficult to cope, and I was referred back in by another GP, previous GP, You know, and I had, for me, urodynamic testing was really, you know, it's a really important validatory tool for me. But it was then again, you know, a few years ago. But interestingly, I had large fibroids removed 18 months ago as part of another operation. And, you know, I thought that it was, I'd sort of didn't, well, I knew that I had fibroids, but not to the degree. And it's amazing having those removed. You know, that has improved. I still suffer from incontinence. I always will do. And there are times when it can be really, you know, really, really, really debilitating. But it's quite interesting that having that operation also helped. Mm-hmm. But I only had that operation because something else sort of, you know, there's a problem with my endometrial wall lining. And I do wonder with women's health, whether it goes back to that, you know, stuff that could be done earlier on. And I think that just, so we've spoken about how I don't have children, never been pregnant, you know, as when pelvic floor issues need to be discussed at point of pregnancy and after the birth. From my point of view, I think that they should be discussed in childhood, but also if the issue is still there, going into transitional care, so moving from adolescent to, or moving from paediatric and adolescent to adult care, and almost a sort of rebooting that just because how a child has been treated, you can't make the same assumptions or the same. You just need to reevaluate when that young person is 16 or 18, because also they become independent of their parents or their caregivers as well. So I think that in adolescence, the caregiver has a really fundamental role, for good or bad, and then suddenly that goes. So it's important to, I think, empower those young people so that they can, you know, their health literacy and so they're better enabled to, you know, to actually speak up and not be cowed because you're speaking to a consultant or whomever.
Ville, you don't have the luxury of being able to say, I'm not going back to get medical care, because your life presumably depends upon caregivers.
Yes.
Have you had any very bad experiences?
No, not very bad experiences. So my spectrum of level of experiences is pretty good, I'd say, in general. Of course, when there is a nurse coming to my home every morning, the variety I've seen during the 10 years, every morning there is a nurse coming. Of course, I've seen a bunch. So some are not as capable as others, but generally people have been very, well, at least adequate in their skill set. And in this sort of situations, it's very important that me, the client of the services, is very, very much the advisor and supervisor in the situation, because I've been forced into a situation where I have to teach a nurse how to do his or her job, and I've probably done that over 100 times or more than that during these years. So I see it as my responsibility to manage the situation so that I can get the best possible care. Because we have to acknowledge the fact that not everybody knows everything, but you know your stuff about yourself the best. So use that knowledge.
And I know from my work that people struggle with intimate examinations, so it's vaginal examinations, anorectal are very, very grim, smear tests, etc. And just taking yourself for a smear test once every 5 years can be quite a trauma. How do you cope and sustain your dignity when every morning someone is coming to do an anorectal examination on you?
Well, you don't see it that way anymore. It's part of life. It's a normal, new normal, as was talked about yesterday. It's a new normal.
Yeah, I suppose so. But I think dignity is quite important. Just how, when someone comes in and greets you in the morning and so on and so forth, that they greet you rather than, your particular, the problem. Yeah.
Yeah.
Yeah. So, absolutely. And I think that you become quite used to examinations and so on and so forth. And as a woman as well, smear tests are hideous in my opinion. I'm sure, there are easier ways of doing it, but you become quite used to sort of being manhandled, for want of a better word, even if it's by a woman. We've, spoken that I don't have this thing that a female doctor is any more caring than a male doctor. And I have for another condition, I have a male doctor, and he always says to me, this is another women's health issue, and he always says, I'm not a woman, so I can't empathise, but I can sympathise. But I've known some women, I did have one particular GP, who was absolutely awful. She really was. So for me, it doesn't matter about sex or gender of the particular clinician. It's, it's their degree of sympathy, empathy, and respect.
Mm-hmm. Yes.
And I like the fact that you talk about training your staff as well that work with you. And one of the things that I do at work is new physiotherapists or nurses who are perhaps anxious about doing internal examinations. I will find a patient that I know will be confident and will work with me, and I won't try and hide the fact they're new. I will say to this patient, this is going to be their first examination. I'm going to be doing it with them. Are you happy with that? We have that discussion. And then everybody's got that confidence as part of the process. And I think if we don't do that, we won't bring up the next generation of clinicians who are able to speak to and support these patients.